So let's begin. As you are aware, several congenital heart defects are the most common serious malformations, surpassing neural tube defects and Down syndrome. Yet they have the lowest detection rate of the malformations listed on this graph. In 2013, ISUOG published criteria for a screening examination of the fetal heart. The suggestion was for the examiner to perform a transverse sweep through the chest from the stomach to the neck. This resulted in imaging the 4-chamber, 5-chamber, 3-vessel, and the tracheal views. This illustrates the image of the sweep and the movement of the transducer on the maternal abdominal wall. This imaging approach is the foundation for much of the discussion that will follow in this presentation. Let's now examine the heart of the first trimester fetus. Historically, the first reported diagnosis of a complex congenital heart defect was published 31 years ago by our group, in which we reported diagnosing a ventricular septal defect, pericardial effusion, ventricular wall hypertrophy, dilated aortic root, and situs inversus. Now let's examine how we can optimize the first trimester image. This is an abdominal image of the fetal heart. Do you see any of the details on this image? You should say no. Okay. This is a sweep of the fetal heart using an abdominal probe. Does a power Doppler help in identifying cardiac anatomy? These are still frames from the video clip. What do these images exclude as far as cardiovascular pathology? The 4-chamber view demonstrates 2 ventricular chambers filling with blood. The left ventricular outflow tract demonstrates blood exiting the left ventricle as indicated by the blue color. The right ventricular outflow tract, represented by the 3-vessel view, demonstrates the main pulmonary artery and the ductus arteriosus and the short axis of the aorta. The tracheal view demonstrates the convergence of the ductus arteriosus and the transverse aortic arch as they enter the thoracic aorta. This clip demonstrates the images I just described. Given the above findings, we are able to exclude the following abnormalities: hypoplastic right and left ventricles, tetralogy of Fallot, truncus arteriosus, detransposition, and coarctation of the aorta. How can we improve the image quality? One approach is to use an endovaginal probe instead of an abdominal probe. This compares the abdominal and endovaginal approach. Notice the improved clarity of the image with the endovaginal probe. Let's now examine the appearance of the heart in the first trimester using the endovaginal probe. This is a normal heart at 11 weeks. Note the bilateral pericardial effusions, which are commonly seen at this gestational age and are not necessarily pathological. This illustrates an endovaginal examination at 12 weeks. Note the movement of the red cells filling the ventricles identified from the 2D image. These are endovaginal examinations at 12 and 13 weeks. Note the color Doppler filling the ventricles at 12 weeks and the details of the 4-chamber view at 13 weeks. This compares 2 endovaginal probes. The clip on the left is a 5 to 9 megahertz probe, and the clip on the right is a 6 to 12 megahertz probe. Note the increased resolution with the 6 to 12 megahertz probe. These clips are sweeps used in the screening examination, which power Doppler has been activated. Again, notice the improved imaging with a higher 6 to 12 megahertz probe on the right when compared to the 5 to 9 megahertz probe on the left. Here's a sweep. What is the diagnosis? Detransposition is suggested because of the single vessel at the level of the tracheal view that is present instead of 2 vessels coalescing together at their insertion into the thoracic aorta. This is a color Doppler sweep illustrating a single vessel observed in the previous 2D slide at the end of the sweep. Another imaging option is HD flow using power Doppler rendering. This is an endovaginal examination of an 11-week fetus. Notice the details of the vascular structures. Another rendered image demonstrates the main pulmonary artery and ductus arteriosus beneath the aortic arch, the ductus venosus, and the pulmonary veins. This illustrates a normal heart on the left and a fetus with a single ventricle on the right. The Doppler on the left is the traditional Doppler display. The image on the right is called radiant flow. Notice the 3D appearance of blood flow using this new imaging modality. This is another example of radiant flow at 13 weeks, identifying the descending aorta, the pelvic origin of the umbilical artery, and the umbilical vein. Radiant flow highlights filling of the ventricular chambers with blood, represented in blue, and blood exiting the left ventricle during systole, represented in red. This is a sweep comparing the grayscale image on the left with radiant flow on the right. Notice how the three vessel and tracheal views are clearly identified. Notice how clearly the aortic arch is displayed. Let's examine several cases of pathology that elucidate the imaging principles previously described. Case 1. This fetus underwent first trimester screening and had a risk for trisomy 21 of 1 in 100,000, a normal nasobone, and a normal ductus venosus waveform. Here's a sweep. What do you see? There is a ventricular septal defect and an enlarged overriding aorta. What does this power Doppler demonstrate? It demonstrates systolic flow along the right and left ventricular septum. In the normal fetus, flow should only be seen along the left ventricular septal wall, but not the right septal wall. This summarizes the views demonstrating tetralogy of flow, which also was associated in this fetus with DiGeorge syndrome. Case 2. Case 2 is a fetus at 13 weeks and 5 days referred for NT screening with no risk factors. What do you see in this clip? The following abnormalities are identified: dilated right ventricle and decreased left ventricle, and a small aorta identified in the 5-chamber view. The power Doppler demonstrates ventricular disproportion with tricuspid regurgitation. What else do you see in this clip? Did you see the ventricular septal defects located in the mid and basal part of the interventricular septum? What's wrong with this tracheal view? This shows the retrograde flow through the transverse arch. These are the results of the analysis: normal situs, ventricular and atrial disproportion, hypoplastic aortic arch, retrograde flow through the aortic arch, and shunting ventricular septal defects. Case 3. This was from a patient with an NT of 2.5 millimeters. What's wrong with this clip? Do you see the hyperechoic septum? This is a transabdominal scan. What is wrong with this clip of the 4-chamber view? Do you see the VSD and the hyperechoic septum? This demonstrates reverse flow in the transverse arch. This demonstrates the VSD with power Doppler. This is a summary of the abnormal findings that included endocardial fibroelastosis, mitral regurgitation, apical VSD, and a hypoplastic aorta with reverse flow in the transverse arch. So let's now examine second and third trimester imaging principles that may assist you in performing a screening or fetal echocardiographic examination of the heart. An important principle to realize that is not always appreciated is the position of the four-chamber view when observed during a fetal examination. This is a distribution of views identified from 100 fetuses in the second and third trimesters. The percentages are the totals for each group observed during the entire duration of the examination. Notice that the apex was up at 12% in 21%, and perpendicular to the ultrasound beam in 86%. The oblique views were present in 64% and 50% respectively. How are we different from the pediatric cardiologist who examines a newborn and pediatric patient? This illustrates the answer. Postnatally, the examination of the heart is performed using specific image orientations which result in specific views. However, the fetal heart can be in a number of different positions depending upon the position of the fetus in utero. If we examine the four screening views as suggested by the ISUOG guidelines, there are over 20 fetal positions and 80 image orientations that we would need to memorize. I'm not sure about you, but for me, memorizing all of these relationships is difficult. So what can we do? I use this simple technique. I always orient the apex of the four-chamber view so that it is on my left. Doing this, I only have to worry about 8 views represented in this illustration. Either the left side is up or the left side is down. To assist me, I can flip the image using the software keys on the machine or simply rotate the transducer 180 degrees. So how do I accomplish this? If the heart is oblique, I move the transducer over the maternal abdominal wall to reorient the beam so that it is perpendicular to the interventricular septum. This illustrates how this is accomplished. Notice how the four-chamber view is reoriented on the screen after moving the transducer over the maternal abdominal wall. Let's now review how to acquire the sweep to image the views described in the ISUOG screening examination. This illustrates a freehand sweep on the left demonstrating normal anatomy. Now my machine labels my images for me, by the way. I don't know about yours does. No. Okay, the image on the right is a freehand sweep, and it demonstrates it's a stick acquisition and demonstrates detransposition. Another option to simultaneously review all of the images suggested by the ISUOG protocol is tomographic ultrasound imaging, or TUI. This is acquired using a 4D probe. Notice how each of the 4 views are easily identified. The clip illustrates the 4-chamber view, the 5-chamber view, the 3-vessel view, and the tracheal view. This evaluates some cases of pathology using tomographic imaging. Case 1. What is wrong with this clip? One clip of the 4-chamber view appears to be normal. And the next level shows the endocardial cushion defect. Case 2. What's wrong with this image? The tricuspid valve is displaced low in the chamber, consistent with Epstein's anomaly. Case 3. What is wrong with this image? Did you see the VSD? The power Doppler elucidates the pathology with an overriding aorta and a VSD. Same fetus. Case 4. What is wrong with this clip? The four-chamber view demonstrates right-to-left disproportion and tricuspid regurgitation. The five-chamber view demonstrates pulmonary regurgitation in the right ventricular outflow tract as manifest by the red flow pattern. The three-vessel view demonstrates pulmonary stenosis with aliasing. Case 5. What's wrong with this clip? The arrow points to a ventricular septal defect that is not observed on the two-dimensional image. This demonstrates the shunting VSD underlying the importance of imaging the heart with power or color Doppler ultrasound. Now let's review how to image the aortic and ductal arches. Most examiners use what I call the wandering approach, in which they move the probe in a random manner. However, there is a systematic approach which I have found useful when imaging the ductal and aortic arches. The first step is to image the tracheal view so that either the ductus arteriosus or transverse aortic arch is parallel to the ultrasound beam. This is represented by the image in the green and red boxes. Notice the position of the four-chamber view in which the septum is oblique to the ultrasound beam. Using the above concepts, the examiner can identify the arches using freehand movement of the transducer. A second approach is to image the fetal heart using a 4D probe and acquire a volume data set. Once obtained, the tracheal view is identified. Lines are drawn along the plane of the ductus arteriosus and the transverse arch. The corresponding views are then displayed for the aortic arch and the ductal arch. A third approach is used a biplane 4D probe that displays two images perpendicular to each other at the same time. Here the reference line is placed in the plane of the transverse aortic arch, displaying the arch on the right when the spine is up. Here the reference line is placed in the plane of the transverse aortic arch when the spine is down. The aortic arch is displayed on the right. Obtaining the four-chamber view for quantitative analysis. This study reviewed the use of a new technology for evaluation of the fetal heart, which is two-dimensional speckle tracking. Using this approach, movement of the endocardium of the right and left ventricles is measured by a number of computations derived, which evaluate the size, shape, and contractility of the ventricular chambers. This is the output from the analysis containing thousands of pixel coordinates. Pretty impressive. Still going. Okay, this is the spreadsheet for computing the ventricular measurements derived from the pixel coordinates. This lists recent studies from our group explaining the number of measurements we have made relating to size, shape, and contractility of the ventricles using speckle tracking software. Following our research studies, this technology has now been implemented for clinical use. This is one of several screens displaying data from such an analysis that is now commercially available and embedded in ultrasound equipment used for fetal assessment. These are a list of measurements of ventricular shape and size that include 24 segment sphericity index, 24 segment transverse width, area, basal apical length, and the 24 segment RV to LV ratio. In addition, measurements of right and left ventricular function can be computed. The entire process, once the four-chamber view is obtained, takes less than 3 minutes to make and complete these measurements. In order for the software used in the previous analysis to accurately compute the measurements, the orientation of the four-chamber view is paramount, in which the identification of the endocardial borders of the lateral and septal walls of each ventricle are clearly identified. The best orientation for these measurements are when the septum is 45 degrees to the ultrasound beam or when it is perpendicular to the beam. The optimal orientation of the four-chamber view is when the left side is down, avoiding obstruction of the ribs, the right side of the chest. When the apex is up, the gain must be increased to elucidate the endocardial borders. By moving the transducer over the maternal abdominal wall, the four-chamber view can be optimized for imaging the ventricular endocardium. Finally, movement of the transducer between the ribs allows for proper orientation of the four-chamber view. This illustrates movement of the transducer in the intercostal space to optimally image the four-chamber view. What about power and color Doppler? This illustrates a traditional color Doppler display of the tracheal view on the left and radiant flow on the right. As mentioned previously, radiant flow provides a three-dimensional view of blood flow, which will be illustrated in the following slides. This illustrates the four-chamber view with traditional power Doppler and on the left and radiant power Doppler on the right. One of the benefits of color or power Doppler is imaging of cardiac structures that are not apparent on the 2D image. Maternal obesity often results in inadequate 2D imaging, but does not affect color or power Doppler imaging. Power Doppler is the preferred modality for identifying the pulmonary veins entering the left atrium. This illustrates tricuspid regurgitation not observed in the 2D image. Another example of tricuspid regurgitation not observed in the 2D image. The 2D image on the left suggests a single ventricle, which is confirmed when color Doppler is used to evaluate blood flow into the ventricle. The image on the left suggests a VSD, while the image on the right demonstrates flow across the defect. The balance has been decreased to reduce the artifact that occurs when the balance is set too high. This illustrates the value of power Doppler for identifying a shunting VSD that was not present on the 2D image at 21 weeks, as well as at 37 weeks. The reason for not imaging the VSD on the 2D image was because of the effect of lateral resolution and the small size of the VSD. This is another example of a small shunting VSD. Contrary to popular belief, a pericardial effusion is not a normal finding. The color Doppler demonstrates movement of the pericardial fluid along opposite in direction to the blood filling the ventricular chambers. This fetus demonstrates significant right-to-left disproportion. The color Doppler does not show flow crossing the foraminal valley from the right atrium to the left atrium. This image from the same fetus shows only the blood entering the left atrium is from the pulmonary veins. The tracheal view demonstrates normal blood flow from the ductus, arteriosus, and transverse aortic arch on the left, reverse flow in the transverse arch on the right. This is the aortic arch demonstrating reverse flow in orange in the transverse arch. The fetus had coarctation of the aorta. Finally, what about rendered color and high-definition flow? This is an example of a rendered fetal heart at 24 weeks, created with a stick acquisition. Notice the details of the vessels, atria, and ventricles. Here is the labeled anatomy of the same fetus. This demonstrates a rendered heart illustrating a ventricular septal defect. This is a rendered heart demonstrating a VSD and pulmonary stenosis. Conclusions. What I've shared with you are many aspects of imaging the fetal heart that I've found useful in my daily practice. Many of the tools that I suggested, that I showed you, are tools that I use when I examine the first trimester fetus or second or third trimester fetus. I've found that for me, what's really been really important is having the same approach when I do the sweep by orienting the heart always the apex on the left. That's because my brain cannot, it has a hard time when I see all these different orientations. It almost has you get a short circuit. So for over 30 years, I've always used the same orientation, apex on my left side up, left side down, as much as I can. And it's really made it easier because I can identify very quickly malformations or abnormalities because I'm so used to seeing the same orientation time and time again. In the adult and pediatric world, you would not have the fetus or have the child walk in the room, climb on the ceiling, turn around and say, now scan me. you have the same orientation, the same position ex utero. We should consider this as an option when we scan the fetus. And finally, color and power Doppler, as well as the 4D probe that I use, can be very useful in identifying and focusing on complex anatomy once you come across a malformation. Thank you very much.